So good afternoon, everyone. Thank you, AIS Scientific Committee. Thank you, all the persons on the dais. So I'll be talking upon giving hope to rejected. So these were the patients who were rejected from few of the hospitals. So HIV positive patient who was with the intumescent cataract, complicated cataract with non-dilating pupil, raised blood sugars, or patients with comorbidities. So not every cataract is straightforward. Few are complicated, few are rejected, referred, or with high risk eyes. So who are rejected? The post-uveitic small pupil fibrotic capsules, hypermature, traumatic or subluxated, immunocompromised patients, HIV positive or HBsAg, HCV positive patients, or poor dilated pupils or scarred corneas. So my practical philosophy is like I choose not to turn them away. I choose a different path to give them a chance where other gave up. So thorough preoperative planning, OCT, B scan with a explained guarded visual prognosis with a documented high risk consent, preferably video consent. So my surgical challenges were like to hope for the best, and always be prepared for the worst. And I always keep my SICS set ready: adrenaline, pilocarpine, AV cutter, AC, IOL, iris claw, IOLs, iris hook, and Gupta's ring or any dilatation ring. No financial interest. So here was a uveitic case. She was non-dilating. With a thorough pre-op evaluation was done. Pre-operative steroids were given to control pre-operative inflammation. I was quiet for 3 months. Her blood pressure and blood sugars were under control. So this was a case. After making the incisions, after giving the peribulbar block and the clear making the incisions, adrenaline was injected.
The video is not coming.
This video only.
Huh? Achha. Sorry.
Yes,
sorry.
yes. So I decided to use Gupta's ring because of the financial constraints. So after inserting the Gupta's ring, sorry, I don't have the video of the insertion, and the careful at the plane phacoemulsification was done. In the bag, IOL was placed and gently the ring was removed. So this was another patient with a HIV positive patient presented to me with a hypermature cataract. All precautions were taken. Disposable gloves, consumables were used, and separate sets for I have a separate set for these patients. I double autoclave rest of the things. And for this patient, she had a high blood sugar levels. So her blood sugar levels were controlled, and 0.3% Nepafenac was used post-operatively with antioxidant, and post-operative OCT was done to rule out cystoid macular edema. So thorough pre-operative planning, well-trained OT staff with preparedness for complication, and maintaining calm composure, positive self-thought can boost your confidence and can improve patient's outcome, thus minimizing the complication in any type of cataract surgery. Thank you.
Just one query. The recording you showed us, was it through the mobile phone or what?
Yes, sir. Yes, sir. That time I didn't have the recording
It
system.
is attached to microscope or somebody is
No,
holding?
somebody was holding it that time.
From the screen?
Yeah.
No, from the TV screen.
From the outside.
From the eye, okay.
Outside, from the
Outside.
eye, yeah.
It was a...
And thank...
नहीं, अच्छा था. That's
No, only thing is Prachi is very nice, but only thing is in complicated cataracts, especially with the VKH syndromes, these are very tough cases because the whole iris is plastered to the lens. It's not because of other complicated cataracts, no, you can just release there's a small membrane which is there in the pupillary area. If you remove it, the pupil may dilate or just remove the synechiae. But the problem is in VKH syndrome, what happens is the entire iris, you need to go and sweep the entire iris all the way. up to the ciliary body or the root of the iris. And I think it's very important. Another thing is zonules are weak in VKH syndrome. And these patients also react very badly post-operatively as well, despite the fact that the eyes are quiet for about 3 to 4 months prior to that. So,
Thank you.
You know, just one comment. See, the kind of cases that you showed, very complex, complicated scenarios, which nobody wants to do, they also require a lot of devices. They require a lot of OVDs, they require iris hooks, dialing devices. The cost on consumables are going to be more in all the cases that you have shown.
So
So
these
sometimes we
all-
do it as a charity and, get a good case to record. So that
Yes.
also is an added benefit. Yeah.
And sir, these were all the cases were rejected from the renowned hospital in Delhi. I won't say, but being the solo practitioner, I have done all the cases. And thanks to my mentor sitting here, Dr. Rakesh Shakya, who made me so I cannot reject any of the case.
Actually, she is very, very fantastic surgeon because during the fellowship period, he did around the 6,000 surgery, even including the glaucoma.
I think I request, Chitrakoot people to donate her the, recording system.
No, sir, I have bought it.
no, that time, yes.
No, sir, it was 3 years fellowship.
3 years.
I think one
3
thing
years.
she highlighted, which we don't discuss many times, patients with, HIV or, hepatitis C, B, like many people would not like to tackle those cases. But taking a universal precaution, there's nothing in the surgery in these cases. And most of the time, cataract surgery is bloodless. And if you take a proper precaution, nothing will happen. You can do a nice surgery of these patients. She highlighted different sets, different machines,
Double globe.
and double globe. Everything has to be disposed. In bigger hospital, you have to wear the different gowns, different double clothes also, and rubber shoes. But all those things are needed for like suppose you're doing a DCR surgery, ophthalmoplastic surgery, a lot of things are coming. Then you'd have to take all precautions. Cataract surgery still you can do very safely and nicely
Sir,
highlighted.
he was roaming in Delhi
Yes.
for around 7 years with intumescent cataract.
Yeah. Thank you, Prachi, for handling all those cases.
Very nice.
Good.